Hi everyone, glad to meet you in another episode of not a medical podcast, but it is about health, specially brought to you by Department of Social and Preventive Medicine, Faculty of Medicine, University Malaya. And we've got an exciting topic today, healthy mothers, thriving children. I'm Dr. Catherine Tamari and I'll be hosting the show today. Kepada para pendengar podcast kita pada hari ini, kami bawakan episod khas buat anda dengan seorang tetamu istimewa di studio bersama kita pada hari ini. Alright, so I've got a very special guest with us today to speak on healthy mothers, thriving children. And this special speaker, she needs no introduction, especially in the field of global health. But perhaps I would provide a brief one and you could start guessing who she is. So this professor, she's currently the visiting professor at the Department of Social and Preventive Medicine. And she is an academician at the Keck School of Medicine, University of Southern California. And she is also the director of the Association of Pacific Rim Universities APRU Global Health Program. And this professor, her past publication speaks of her remarkable research work, especially in the domains of maternal health, sexual and reproductive health, gender-based violence, migrant health, health equity, to name a few. Could you guess who she is? Well, it's none other than Professor Dr. Melissa Withers, right here with me in the studio. Welcome, Prof. Melissa. How are you doing, Prof?
Good. Thank you so much for having me. It's a delight to be here.
Yes, it's a pleasure having you with us for our discussion today, Prof. So perhaps to start with today's topic, when we say healthy mothers, thriving children, what does that really mean from a global health perspective, Prof? Could you tell us?
Yes. Well, healthy mothers certainly means more than women just survive pregnancy and childbirth. It means that they have access to quality antenatal care, delivery, and postnatal care, but also that they have proper nutrition, mental health support, they can achieve their reproductive rights. And we know that maternal health and newborn health are closely linked. So it's important to remember that, right, with skilled birth attendants, timely management and treatment, this can make a huge difference in the life and death for women, but also for their newborns. We know that thriving children means not only surviving infancy, but really growing up, developing, and reaching their full potential. And so that means a whole host of services, access to nutrition, vaccination, education, and of course, safe environments.
All right. Thank you. Thanks for that, Prof. And we see most of the time maternal health is discussed in terms of individual outcomes, especially during the pregnancy checks, in terms of the mother's nutritional status, symptoms of gestational diabetes, gestational hypertension, and so forth. But I believe there is more to it. Could you tell us, Prof, how does maternal health actually reflect the overall health system as a whole?
Sure. Yes. We often use maternal health care indicators as a proxy for the entire health system. Because when maternal health is good, we can see that the overall health system functions well. And when it's bad, it's an indicator for many things potentially going wrong. So why is it a proxy? Because it really depends on almost every part of that system working well. If it's weak, it's exposing deeper problems. So imagine a pregnant woman doesn't need just one service. She needs a whole continuity of care, from antenatal care, skilled care during delivery. That includes potentially emergency obstetric care like C-sections, and of course, postnatal care. If a country can provide all of these consistently, it shows good service delivery and strong coordination within the health system. But it really depends on the whole health system infrastructure. A safe birth requires, for example, equipped health facilities, clean water, supplies, electricity, medicine, even transportation and referral systems. So if a woman cannot reach a hospital or clinic, or if the hospital lacks supplies or workforce, it reflects system-wide weaknesses, not just in maternal health. And it reflects the quality of healthcare workers, right? We need skilled doctors, we need midwives and nurses who have proper training and supervision. So if we have shortages or poorly trained staff, that also usually indicates broader human resource problems across the entire system. We also know that it can reveal equity issues and access issues because maternal health outcomes are going to vary quite dramatically between income levels, rural versus urban locations, and educational levels. So high maternal mortality rates often signal inequities in access to healthcare. So that affects all populations, not just mothers. And finally, think about involving emergency readiness. Complications can happen really quickly and escalate. So a functioning system has to be able to respond really quickly to hemorrhage or eclampsia, providing emergency surgeries or emergency blood supply. And so if it's failing there, it's showing weaknesses in emergency and critical care systems throughout the entire health systems. So really, it makes it a strong indicator of how well health systems also are interacting with social systems, because we know maternal health is influenced by nutrition, by education, by policies at the public health level, and also by gender equality issues.
All right. So there's a lot to it, Prof. So you spoke about complications in pregnancy specifically. So could you tell us more what could be the contributing factors to poor maternal health outcomes?
Yes. Well, it's complicated because there really are so many. We know that every year around the world, so many women are dying. About 260,000 women died during and following pregnancy and childbirth last year, for example. So that is unacceptably high. And it's just shocking to me that we're still seeing so many deaths, largely from preventable causes. That's 700 women plus who are dying every single day from these preventable causes related to pregnancy and childbirth, like sepsis, like preeclampsia. We know many of them have limited access to skilled care, and that's really an important reason why we're seeing these preventable deaths.
Right. So given these challenges that you just listed out, Prof, I believe there are many global efforts which has been put in place to address maternal health at a broader level. And how do you think the Sustainable Developmental Goal SDGs address maternal mortality?
Yes, well, they specifically address maternal mortality in quite an ambitious way, actually. So SDG goal number 2.3 says that we should decrease the maternal mortality ratio to 70 deaths per 100,000 live births by 2030. So we have made pretty significant progress since 2000. We have reduced the maternal mortality ratio by 40%, actually, between 2000 and 2023. But yet, too many mothers are still giving birth without skilled support. Clinics are running without even the basic supplies, and babies are missing life-saving vaccination opportunities. We know that the latest available suggests that in most high-income and even upper-middle-income countries, about 99% of all births are in the presence of a trained professional, whether it's a midwife, a doctor, or a nurse. But in low-income and lower middle-income countries, we're seeing only 73 to 84% of those births attended by a skilled health professional. We also know that the WHO back in 2016 recommended, it updated its recommendations for number of antenatal care visits from 4, right, up to 8 or more visits during pregnancy. But if we're looking at the numbers, most women have some skilled antenatal care at least once during the pregnancy, but only about 70% are receiving 4 or more, let alone the new recommendation of 8 contacts. So there's still a lot of work to be done. 4 in 5 countries are set to miss the SDG goal, to miss these global maternal survival targets by 2030. Maternal mortality is actually considered to be one of the most off-track indicators for the SDGs. If we want to achieve this, so right now we're at about 197 deaths per 100,000 live births, well above the target of 70, right? If we want to reach this target by 2030, it's going to require an annual rate of reduction of almost 15%. And that rarely has ever been achieved. We have the scientific knowledge, we have the medical knowledge, we have the tools to reduce these deaths and to reach these targets. But because of lack of prioritization, we're not making enough progress.
All right. Thanks, Prof. So we know we have the SDG in place as part of our global efforts. But as you said, Prof, why do we still see such large disparities, I would say, in terms of maternal and child health outcomes between countries or even within the same country in different settings or localities, Prof?
Yes. We're facing that trouble in my own country, in the United States, where we're seeing huge disparities between Black or African Americans and other racial ethnic groups, with African Americans having much, much higher rates of maternal mortality. So we know the number of maternal deaths in many areas of the world reflects inequalities in access to quality health services. And this really highlights the gap between the rich and the poor in these countries. So just take a look at comparing by income level. The maternal mortality ratio in low-income countries is close to 350 per 100,000 live births. In high-income countries, it's 10. So huge disparities, unacceptable disparities in terms of maternal health care. And if we look at the lifetime risk of maternal death, right, that's the probability that a 15-year-old woman will eventually die from a maternal cause in that country. And that's assuming that fertility rates stay the same. Across most of the world, the risk is less than 1%. In fact, in most countries, it's well below even 0.1%. But in low-income countries, the risk is 1 in 66. So that's, again, very illustrative of the enormous disparities. We know, and the WHO tells us, that over 90% of maternal deaths occur in low and middle income countries. And we know that these deaths are almost entirely preventable. In particular, sub-Saharan Africa accounted for about 70% of all of global maternal deaths, but only about 15% of the world's population lives there. We're also seeing that countries that are in conflict or experiencing, social fragility are accounting for a much higher proportion of global maternal deaths. And also poor women in remote areas. So geography is also a contributing factor. It's a determinant of access to maternal health. So in regions with relatively low numbers of skilled healthcare providers, such as in sub-Saharan Africa and even parts of Asia, we're seeing women in remote areas disproportionately impacted in terms of quality maternal health care services. And actually, we can apply what is called the 3 delays model to this. I'm not sure if you are familiar with that model, but the 3 delays model is a model that was developed in the 1980s, actually, by 2 researchers, Thaddeus and Main. And it explores maternal mortality as a result of 3 delays. And these delays are delays in seeking care, delays in reaching a health facility, and delays in receiving adequate treatment. So we really need to look at the individual context and determine where the delays are happening. So the first delay in deciding to seek care, well, this is happening at the household or sometimes a community level. So it might be that there's just a lack of awareness about the danger signs, bleeding, something like that, high blood pressure. It could also reflect the cultural beliefs or preferences in that community for home births. It could be because of gender inequalities and low status of women in that community that maybe the women aren't allowed to seek care. They need permission to seek care, or they need a male family member to accompany them. Or there might be also financial constraints. I can't afford to seek care. And so that's the first delay. The second delay, again, is delay in reaching a health facility. So even after the decision is made to seek care, in many settings, especially those in remote areas, getting to care can be really difficult. It could be there are really long distances to go to the hospital or even a clinic, or there's lack of transport or high transportation costs or poor roads, and it's just really hard. So the woman gets to the health facility too late and maybe already in critical condition. And so those represent a different set of barriers, right? And then the third delay is the delay in receiving adequate care. And this delay happens, of course, at the health facility. So common issues might be there's a shortage of trained staff. There's a lack of equipment, the lack of medicines or blood supply, or there's a really slow response, long wait times, or poor quality of care. And so for whatever reason, that woman does not receive timely or effective treatment. And so by applying this 3 delays model, we can look at the specific context and decide where are the problems and where are the barriers and how can we work to solve those barriers.
All right. Thank you, Prof, for that clear explanation in terms of the large disparities that we see in different locations. And of course, for sharing in terms of the 3 delays as well. I think that's very important for us to look into. So, Prof, we know there is a lot to be done, especially in the areas that we are not doing much. So could you share, where should we be actually focusing our efforts in improving maternal health outcomes?
Yes. That's a tough question because there are so many different areas I think that we could work on, and we certainly need to work on it from a multi-pronged approach. But I'm a little bit biased here, so I will just talk about my own research interest in family planning. I think one important way to avoid maternal deaths is to prevent unintended pregnancies. Those women who have unintended pregnancies are often the ones that also have the highest risk for maternal death, whether they be young women or older women or women who have already had a lot of kids or who have had difficult pregnancies and births and complications in the past, right? So it's really important that we work to prevent these unintended pregnancies in order to meet reproductive rights, right? And to reduce maternal mortality. And if we look around the world, there are about 164 million women who have an unmet need for contraception. So we have close to 2 billion women of reproductive age worldwide, and about 1 billion of those have a need for family planning. And so 874 million are using contraceptive methods, but that means 164 million aren't, but yet have reported that they don't want to have children in the near future. And so to me, that's almost like an easy problem to solve. You don't have to convince them not to have more children. They already said they don't want more. But this problem of unmet need for contraception highlights a significant gap between reproductive intentions and contraceptive use. And there are, a lot of reasons why they're not using a contraception, even though they want to avoid pregnancy. So if we work on this issue, we're reducing unintended pregnancies, which means we're lowering maternal health risks, especially for like adolescents, but we're also lowering child health risks, and we're promoting broader development goals, including making sure people have access to education and economic opportunities and better nutrition, because we're allowing people to have smaller families that they can afford. And of course, it also aligns with the SDG goal 3.7 for universal access to sexual and reproductive health care.
Right, thank you. Prof, so based on your prior work, you shared with us in terms of the importance of family planning and things on that. But I would also be interested to know about your past work on maternal mental health. Could you share with us on that, Prof?
Sure. Yes. So I've done quite a lot of work in recent years on looking at perinatal depression. And it's clear that in many places, especially LMICs, low and middle income countries, that women are suffering with perinatal depression. We're seeing prevalence rates of up to 20% actually in LMICs versus about 10 to 12% in high income countries. But yet it's an area that's really has not been addressed very well yet. Many countries are not screening at all for perinatal depression. And this is something that, again, that can influence not only the health of the mother, but also impacts negatively the health of her new baby, because women who are depressed have more challenges in breastfeeding, in bonding with their children, and also in attending the well baby visits where they can get important access to things like vaccination. So we need to start screening for perinatal depression. We need to make people aware that this is even a thing, that something to look out for during, pregnancy and postpartum, and also let the families know that sometimes, okay, these are the red flags. Sometimes the women, experience this issue, and let's support her. Let's get her some help if needed.
All right, Prof. So my next question for you, what are the biggest barriers that you think are preventing mothers from accessing quality care during pregnancy and childbirth? Tell us more about it, Prof.
Yes. Okay. Well, I've talked with about some of them already, like health systems failures or lack of access to education and maybe low income or low awareness. But there's also something I wanted to raise that I think is receiving more attention in the literature, And that is called maternal disrespect, or it's also sometimes just called maternal mistreatment. So maternal disrespect really just refers to the mistreatment of women during pregnancy, labor, and delivery within healthcare settings. It's actually a major quality of care issue that's now been recognized by the WHO. And we may think, wow, does that really happen? Does that really happen that women are during a very vulnerable period, during childbirth, for example, that they're actually being abused within the healthcare system? And the answer is yes, it actually does happen, and it's more frequent than you think. So this term really describes any behavior that, of course, it's violating women's dignity, rights, and autonomy while receiving maternal care. So they're not just being denied quality or good care, but they're being treated in ways that are actually harmful, abusive, humiliating, or neglectful. And there are lots of examples. Common forms of maternal disrespect. It could be physical abuse, like slapping or hitting them, or forcing procedures without care. A lot of verbal abuse happens, like blaming women or humiliating comments, scolding them, shouting at them. There are actual procedures that are performed without informed consent, not explaining what's happening, not getting their approvals for things like episiotomies or C-sections. It might be lack of confidentiality or privacy. So like exposing, body parts unnecessarily, or discussing personal information really openly with others present. It could be even neglect or abandonment, like ignoring women who are in labor, so not attending to their needs, delaying attending to their complications. It could be even holding women in hospitals for failure to pay their bills, which still happens in some settings. And certainly we're seeing discrimination on the part of providers based on things like for teenage mothers, right? So age, migrant status, HIV status, socioeconomic status, etc. And so this is an important barrier because obviously it's discouraging women from going to clinics or hospitals. It discourages healthcare utilization. Women who think that they're going to be abused or humiliated are going to avoid going to hospitals during future pregnancies as well. And it's then leading to more home births without skilled care. And it also contributes to poor outcomes, right? So going back to those delays and the 3 delays model, it then increases the risk of complications. And why does this happen? Well, it's not that all healthcare providers are bad. I'm not trying to say that at all. But a lot of them have overburdened staff, maybe poor training, weak accountability systems. And so organizations like the WHO have come up with the RMC, or respectful maternal care, which helps to provide guidelines. It outlines practices that support dignity and privacy, informed consent, and emotional support. So it's both a human rights issue and a sign of poor health quality, but it really can discourage women from seeking care either with this pregnancy or with future. And so it's a barrier that's not often recognized, but something I wanted to bring up today.
Yeah, thank you so much, Prof, for highlighting that barrier, maternal disrespect. All right, Prof, I think moving on, I would like to explore more in terms of your past publication. So, Prof, your research emphasizes a life course perspective. Can you tell us more about what that really means and how that's related to maternal health?
Yes, absolutely. So the life course perspective takes into account critical periods in a woman's development and really recognizes that experiences are shaped by the wider social, economic, and cultural context in which they take place. So gender inequities affect girls and women at every stage of their lives, placing them at a disadvantage to men, and that influences their whole life trajectories. So women certainly may be at heightened vulnerability and risk of exploitation or violence during some key milestones in their lives, whether it's sexual debut or marriage or pregnancy. But this perspective encourages us not to examine each of these milestones in isolation, but rather to consider the intersection of biological, sociocultural, and behavioral factors that influence women's health and how these accumulate over a woman's lifetime. So we have to think about how present experiences are not only shaped by the past, but will in turn also affect future experiences. And so the significance of early experiences in particular on influencing conditions later on in a woman's life cannot be overemphasized. So interventions to support and empower girls early on are really, really crucial. We aspire to the best possible health outcomes for women, of course, at every stage of their lives, and that means starting very, very young.
All right. Thanks, Prof. I think we have explored much in the domain of maternal health. Perhaps one last question from myself, Prof. What would be your message to our listeners today, the academicians, the lecturers, the researchers, and perhaps students who plan to be working in this research area?
Yes, well, first of all, I'm so happy to hear that more people are interested in working in this area. There's so much work to be done in the area of maternal health, and it really is such a rewarding career, right? A rewarding research topic, because you're really able to make an impact, not just on women's health, but on their entire families. We know that it will affect their children and their family structure as well. So there are really a lot of opportunities to get involved, whether it's with health systems research or translational research, whether it's looking at cultural barriers, gender equality issues. There are just so many ways to get involved. And we know every 2 minutes, a woman dies around the world during pregnancy or childbirth. We have the tools to change this. And so I hope that more students and researchers will be motivated to get involved to make this difference.
Right. Thank you so much, Prof. And as we conclude today's conversation with Professor Melissa, I think we're all reminded that investing in maternal and child health is not just about reducing the mortality, it's not just about bringing down the cases, but it's about building healthier families and stronger communities and a better future for all of us. Thanks once again, Professor Melissa, for being here with us as our special guest and for your time and for sharing your insights, your valuable experiences with us today. And thank you to all our listeners for joining in this special episode of not a medical podcast, but it is about health. And I hope that this conversation has given all of us a deeper understanding on maternal health. Ya, kepada para pendengar kita, pastikan anda kongsikan podcast ini bersama rakan anda, bersama saudara anda jika anda dapati podcast ini bermanfaat. Juga jangan lupa kongsikan kepada kami, berikan cadangan topik-topik menarik yang ingin anda dengar daripada kami. Anda boleh berikan cadangan dan mungkin kami akan cuba bawakan topik-topik tersebut di episod-episod yang akan datang. Alright, dan saya rasa kita semua dapat belajar dari perbincangan kita hari ini mengenai kesihatan ibu dan kesejahteraan kita bersama. Terima kasih semua. Thank you.
Terima kasih, everyone.
Thank you, Prof.
Thank you for having me.